Hey everybody, welcome back to the You Are Not Broken podcast. I have not done an Instagram Q&A in a long time. So I actually posted on stories a little bit ago to tell me your questions. And I got like 15 times a lot of questions. I took a bunch of screenshots because it's hard to do everything on phones and all the things. So anyways, I don't know how many questions, but it's a ton. So I poured myself a cup of coffee. I am recording live for a future podcast. I'm on Instagram right now, and I'm going to go through a bunch of questions while I drink coffee. Coffee and questions. I haven't done a live Q&A in a while, so here we go. Starting off the top, how do I do strength training? I've had a rectocele repair and can't lift weights. Who says you can't lift weights? Where'd that come from? Of course you can lift weights. After prolapse repair, so I'm a urologist, a surgeon who does a lot of prolapse repair and continence work. In addition to my side gig of this, I'm hosting this amazing podcast. So I feel like I am pretty expert at answering this question. If somebody told you that after your prolapse repair, you can no longer lift weights, like that's detrimental to your whole body. See all the reasons that lifting weights is good for you. So when I do a prolapse repair, we have no lifting over 10 pounds for about 4 to 6 weeks. We want our sutures to heal, but then I send you to physical therapy because I always tell people I fix bulges, but I don't make you stronger. So you've got to go and get strong. Bulges are hernias, right? So we need our core to be strong. We need our pelvic floor to be strong. We need to learn how to lift by engaging our core and not pushing out through the hole in our pelvis, which is where prolapse comes from. So I disagree with you not lifting weights. Get an opinion on that. Get a physical therapist on that, and start doing some strength training. But make sure that you are getting evaluated for the pelvic floor and core so that you cannot hurt your repair. I did have somebody blow out her rectocele repair because she was baling hay, like legit the round bales of hay. So it happens. Recurrence of prolapse over a woman's lifetime, about 1 in 5 or 20%. That means 80% of people's prolapse doesn't come back. Okay, great question to the start of this podcast. Number next, any research on menopause effects on gastrointestinal health? How about after HRT? Yeah, super interesting question. So our gut microbiome is dependent on many things. One of those things is hormones. There is some data that when estrogen levels go down, that your microbiome does change. Tends to look more like a gut microbiome of a man. And that's one question of, is that why women's risk for colorectal cancer goes up after menopause? Is that one reason that in the WHI study that risk for colon cancer was decreased by 30% for people who were taking hormones? So yes, there is some research on menopause effects on GI health. Also just a lot of people who kind of notice increased bloating, GI changes after menopause. There's some work looking at microbiome probiotics post-menopause. You'll see that in the menopause supplement world. I'm not fully convinced on a lot of more data needs to happen, basically. But yes, your microbiome does change when your hormones change. You guys, everything changes after your hormones change. Don't think this is just hot flashes and no periods. Real quick, what do you think about PTNS for your urgency incontinence? PTNS stands for peripheral tibial nerve stimulation. It's basically like a acupuncture needle in the tibial nerve down by the ankle. I think it's time consuming, meaning you have to come in a lot to get these treatments. And I think that it doesn't work as well as Botox or sacral neuromodulation. That said, they're coming out with the new implantable ones, and they're coming out with the new ones that you can just strap on and have at home. So if you don't have to go into the clinic every week for this, it's certainly less time consuming. So I don't hate on it. I think that there are better options currently, but the future looks good. Okay. Are there optimal levels of hormones for women 60, 70, and 80? We do not have enough data to answer this. I cannot tell you that you should be at a level of 50 or 80 or 120. We don't know. We don't have data to say what is the best estrogen level for brain protection. We're like hardly saying, and I think we're just starting to say, that estrogen is dementia protective when started early, within 10 years. Hormones do not treat dementia. They prevent dementia, but you've got to start on it early, and we don't have levels to say this level is great for bones, this level is great for heart, this level is great for brain. Likely our body, right? What we can say is bones respond at a very low level of hormones. But what do we need for skin? What do we need for a systemic level so that you don't need additional vaginal estrogen? Lots and lots of questions. Okay. What are top arguments for my gyne to put me on testosterone? I'm 46 and perimenopausal. Top arguments? First of all, it shouldn't be an argument. But maybe you're not thinking about it in that sense. So, because you want to, there's something called bodily autonomy, which I think is being chipped away. But when I trained in medicine, it was called patient-doctor shared decision-making, and that was all the rage. Somehow that's like gotten to the sidelines where like we just have to do what the doctor says, who have not been trained in testosterone or menopause for that matter. So I think the top argument is at 40, your testosterone levels are 50% what they were when they were 20. There are many studies looking at the multitude of benefits of testosterone in women at women physiologic doses. We're not trying to turn anybody into a man or live like a man unless they choose that. It's a much higher dose, 10 times the dose. But if you have to go in and you have to argue with a provider about being on any hormones or testosterone, maybe it's time to see another provider. When I see women, women who come to see me tend to be very educated because they know what I do. They know my podcast, they know my Instagram, they know my books. So they tend to come in and they're like, I want to be on testosterone. And I'm like, great. I already know that they're educated and they know the pros and cons of it and the safety of it. So, but if a woman comes in and she doesn't know anything about hormones, I'm not pushy. Like, I'm not going to push her on it. This is her personal decision. She doesn't have the education enough to say that she wants it. I'm not going to push her on it. I'm going to say how good hormones are, but it's her decision. So it's her decision to not go on hormones. It's her decision to go on hormones. Bodily autonomy. If I try transdermal or testosterone suppositories, will I also suffer from acne hair loss? Side effect of testosterone supplementation is greasier skin, acne, and some hair growth on the face. Most people who get within a physiologic or slightly above physiologic female dose don't complain of this too much to the point that they want to stop. I don't know what you mean with testosterone suppositories. It's not really a thing. Maybe you're talking about pellets. So if you're talking about pellets tend to push you at a much higher testosterone level. So that's when we see kind of like the shock to the system where you're going to see hair, top of hair loss. But with the physiologic ranges that I get with either transdermal gel or a compounded cream, I'm not seeing much in the way of bother of certainly hair loss. Haven't seen it. So dosing matters. Like, check your levels, see where you're at. And I always say, start low, adjust to it. See if you like it. See if you like your level at being 80. See if you like your level being at 50. Pellets are going to put you into 150, 200, 250, 300. Those are not physiologic female doses. And I do think some people do better at those doses, but I don't think that's where we should be starting women with testosterone. All right, those are some good questions. Let's go back and get some more questions. Cystocele versus rectocele, difference and treatments, please. Okay, great question. Cystocele is the anterior part of the vagina sagging down. Rectocele is the posterior part of the vagina sagging in. Go back to my podcast It's literally called Prolapse. You can find it on my website too. Spend over an hour talking about the difference between all of those and treatment plans, surgical, non-surgical. So go see it. Very common and very treatable. Pelvic floor physical therapy is your friend. Breast tenderness since starting estradiol gel 6 months ago. BID level still low. I don't know what BID level still low means. And you're 63. We tend to have you back off a little bit. You could try some progesterone and testosterone. So play with it. Make sure you're seeing an expert who can adjust all those things for you. 54, in full hysterectomy, OB-GYN won't prescribe me progesterone, but online doc service will. Why? Good question. So progesterone is mandatory if you have a uterus to protect the endometrial lining from unopposed estradiol supplementation. So a lot of people will think that if you don't have a uterus, you don't need progesterone, but progesterone is great. It works in the brain. It's great for mood. It's wonderful for sleep. So it's becoming more common now to be air quotes allowed to be on progesterone if you don't have a uterus. And where did that come from? It came from the synthetic medroxyprogesterone acetate, thinking that it's probably the bully from the WHI in regards to adverse effects. So that we don't use that medication anymore, except for incredibly rarely and for other things. So that's kind of where the no, you can't have it if you don't have a uterus came from, of trying to keep people off the synthetic. But micronized progesterone, very safe, quite beneficial, and you can be on it if you've had a hysterectomy. You guys, not all gynecologists know these things. So what am I saying? What I'm saying is see a hormone specialist if you can. And if they tell you something that isn't resonating with what the hormone experts are saying, it's probably because they don't have up-to-date menopause training. Risk of blood clots from estrogen patch, not any higher than your risk of blood clots from living. It's transdermal. It doesn't go through your liver. Therefore, it doesn't increase your clotting factors. We have multiple papers on this. Understand the physiology. That's how you get rid of fear. At what dose do I start with testosterone gel? So testosterone gel, I think what you mean is the androgel or testum, which is the male-dosed product in America. You're going to start at 1/10 the dose, and you're going to recheck your levels 6-ish weeks after, just to see if you've moved the needle and how you're feeling, and then you can always go up or go down. So 1/10 the male dose. If you compound that in a cream, it's going to be 5 milligrams a day. All right. Some of these questions I can't answer because I'm not a gynecologist. You guys, I'm not a gynecologist. I am a urologist. I don't know all the gyne questions. Another question about average dose of testosterone. There you go. 65, never took hormones, still having hot flashes, have osteo and a leaky heart valve. Can I take hormones? Probably. See an expert. Best window to start for prevention of disease is within 10 years. So transdermal is going to be safest. But yeah, see a specialist. You guys, one of my top listened to podcast episodes is called The Boomer Should Be Pissed. And the myth that you can't be on hormones after age 60 is not true. They simply say the greatest benefit and the least amount of risks is when you start on hormones before your body's adapted to not being on hormones because of aging. So you're just less, I'm sorry, you're just less healthy the older you are. So there can be more risk to things, but the risks of starting hormones in an older person is still very, very low. I literally could open up a clinic just treating boomers and hormones because they're such an underserved population. Love your show. You've given me knowledge to have better conversations with my doctors. That's not a question, but I love it. It's a compliment. Thank you. Does deep infiltrating endometriosis mean you can't take estrogen in menopause? No. I have many women who've been surgically treated for endometriosis and who are now on hormones. Don't forget testosterone and progesterone. But many, there's actually a paper on this looking at recurrence of endometriosis with hormone replacement, estrogen. It's incredibly rare. I was just on a group chat with a bunch of people, including many gynecologists, and they're like, they haven't seen it. So many happy older, and you guys pause for the cause of stop oversimplifying things. Endometriosis is not just because of estrogen. If that was true, everybody who had estrogen would have endometriosis. It's not that simple. Therefore, there's something else going on, which we need to figure out, but it doesn't mean you can't have estrogen afterwards. I've never known anyone to be tested for progesterone. Why is that? Fantastic question. With blood work, the range for progesterone when you're not like cycling or trying to do IVF is really low, and it's very hard to interpret. And we never treat to a level anyways. So if you're having symptoms of low progesterone, we just treat you. It's like an incredibly safe medication. Why it's not over the counter, I'm not sure. But that's why you'll see saliva people checking progesterone. Then you get into the weeds with like estrogen progesterone ratios. That's not standard menopause care. It's pretty nichey, and most people say for the average woman, that's not necessary. I would only get into that if they were still having symptoms after like standard trial of medication. So yeah, we don't usually check progesterone. If T is out as option for females, what can help with low T? Why is T out as an option for females? That question doesn't even make any sense. We don't have an FDA approved testosterone dose in this country. That doesn't mean women can't take testosterone. There's lots of things we do off-label. Remember, the FDA does not practice medicine. The FDA will say we don't practice medicine. They can approve medications for indications, so they play a very important role. But just because they don't have a product at a dose that works for you doesn't mean you can't use that prescription. All right. Besides how I feel, what are lab levels do I use as a guide for HRT and dosing? Great question. I think this goes back to like, people think there's like a one size fits all and we just need to dial you in to like all 50-year-olds should be here. That's not how this works, you guys. We're all amazing, beautiful snowflakes. I care about how you feel. How do you feel? I don't chase numbers. I'll use numbers if I'm like, you're on a really high dose. Let's just make sure this isn't like crazy high inside your body. So I'll look for that. I had one woman, she swore up and down that low estrogen was why she wasn't sleeping, and she was on a very large dose of estrogen. So I checked it and her estrogen level was like 1,000, and she's like, is that good? And I'm like, not if you're pregnant. Like that's like a pregnant dose. So I was like, I don't want you to live at 1,000. I don't have data to say what living at 1,000 all the time does, because humans don't do that. So I'll check labs kind of to prove like you're absorbing the product or whatever you're feeling is not because of that hormone being low. If you have blood clotting issues, what are your safe options? Transdermal. All right. These are great questions. Has research been done to verify if estradiol applied to face causes pigmentation? In some people, it can make, so they're talking about low dose facial estriol or estradiol to improve collagen, skin texture, thickness, reduce wrinkles. In some people, especially if they're prone to melasma or have melasma, which is like a darkening kind of irregularity of the skin, that product can increase the melasma. So in those people, I'd say maybe it's just not worth it for you. But in the average person, I haven't seen that it causes melasma. People are just saying it makes my melasma worse. So you already are kind of prone to being sensitive to have that going on. What else do we have? Do these get saved anywhere? Yeah, this is going to be a podcast episode. Good, good. Somebody says they have reflux with starting estrogen and oral progesterone 2 months in. Options. Yeah, I would play around with other administrations. Is it the progesterone? Is it the estrogen? Play around with it, and that's where you're going to need to see an expert on like options for that. Too much for a general use podcast education. What options for testosterone? Pills, creams, injections? Also, my OB-GYN says no. Okay, remember, OB-GYNs didn't get trained on testosterone. Most of them still think it's a male hormone. So, like, they're not always the best people to go to. Testosterone, lots of different options. Oral, Kysotrex is a brand name oral. Be picky with oral. No compounded, no anything like that. Even the methyl testosterone is a synthetic testosterone. I stay away from it. There was a JAMA article looking at increased rates of breast cancer. So I don't like the methyl testosterone. So that's synthetic testosterone. The testosterone I like is bioidentical. Cream, gel. So cream is compounded. Gel is dosed 1/10 the male dose. You can inject it. There's no patches in America right now for it. And then pill would be something like Kysotrex, where it is safe for the liver. I don't like troches. Probably they're transdermal. I just haven't seen enough data on safety and if any of that gets into the hepatic system. Troches is something that goes in your cheek. So also don't forget pellets. You can get testosterone pellets. Almost forgot about testosterone pellets. Okay. Any tips on what to do during broken ankle healing as no exercise is allowed? Yes, good question. I just had this because I just had kind of a knee injury, and we lose muscle fast. So the question is, can you be on a sit down recumbent bike with the other leg? Can you move the other leg? Can you do some upper body? Can you be laying down supported with bench press and do upper body? So lots of different questions on that, but I would say you just stopping cold turkey is going to be your greatest risk of muscle loss for sure. So I'd say don't do anything. Let your ankle heal for sure. Don't stress that, but see what else you can do for the rest of your body. All right.